So this is an addendum to the scalp and the skull class that Professor D.R. Singh took on the 3rd and 4th of January 2019. If you look from the top of the skull, it is Norma verticalis. From the front, Norma frontalis. From the back, Norma occipitalis. From below, it is Norma basalis or basis cranii externa. From the side, it is Norma lateralis, right or the left. Now, if you cut off the top part of the skull, you can view the base of the skull from inside. So that is called as basis cranii interna. And this is your view after you've removed the calvaria. So these are the normas. So this is the frontal bone in front and the two parietals and the occipital bone behind. The frontal bone and the parietal bones have a suture which lies in the coronal plane. So it's called as the coronal suture. The interparietal suture is also the sagittal suture. Behind, there is an inverted lambda-shaped suture between the parietals and the occiput and later the temporal bone. So that is called as the lambdoid suture. So occiput is behind, frontal in front, and temporal you can see. The temporal has a process which goes forward and fuses with a bone with 3 arms. The upper arm fuses with the frontal, the anterior arm fuses with the maxilla, the posterior arm fuses with the temporal. Below this, which is the zygomatic arch, you can pass your fingers under it and you reach a place where there is the vertical wing of the sphenoid bone. So this greater wing of the sphenoid has got a vertical part, which is the sphenoid. So this is the ear is the external acoustic meatus of the ear is where it is marked there, and the skull is actually resting on the mastoid. Then you have the orbit, you have the 2 nasal bones, you have the nasal cavity which is divided by a septum, and then you have the alveolar arch of the maxilla. So if you really hit a box, you will really hit it at the zygomatic. In the scalp, the skin, all are bothered about the white or the black hair. They color them and destroy them. There's baldness, there's implantation, and there's avulsion when long hair get entrapped into machinery. Since the scalp is so vascular, so you can stitch it in place and the wound would heal. In the connective tissue, since it's a dense connective tissue, it doesn't allow vessels to collapse in injury, and there's profuse bleeding, which can be checked by pressure. If the aponeurosis is ruptured, this will allow the wound to gape. But the bleeding may be less, but the wound gaping, there will be because the aponeurosis is ruptured. The aponeurosis in front is attached to the frontalis muscle supplied by the anterior branch of the facial nerve, and you in surprise, you lift up your eyebrows by the frontalis muscle. Behind, it's the occipitalis muscle, which is supplied by the posterior branch of the frontal nerve. If there's a hemorrhage in the loose areolar tissue, it will go below the galea aponeurotica, below the frontalis muscle into the orbit, causing a black eye. And in the subconjunctival region, in the upper lid, you may have a flame-shaped subconjunctival hemorrhage. If there's a hemorrhage below the pericranium, then it will take the shape of the bone because of the attachment limitation by the sutural ligaments. The loose areolar tissue is connected to the deep sinuses by imagery veins, and therefore any infection in the loose areolar tissue can lead to infection of the sinuses and thrombosis or the clotting within the sinus. This is the basis cranii interna. And of course, you can see this picture again and again and revise the frontal crest, the foramen cecum, the crista galli, the cribriform plate, the orbital portion of the frontal, the lesser wing of sphenoid leading to anterior clinoid process, the jugum sphenoidale, the tuberculum celli, the sella turcica, the dorsum celli, the two optic foramen, the superior orbital fissure, the foramen ovale passing the male, which is the mandibular nerve, accessory meningeal artery, lesser superficial petrosal nerve, and imagery vein, foramen spinosum behind it passing the middle meningeal artery, foramen lacerum passing the internal carotid artery, which has a F-shaped course on the side of the body of the sphenoid, and which lies in the cavernous sinus, along with the oculomotor, trochlear, ophthalmic, and maxillary nerve, and the sixth nerve, which is the abducent nerve. Then you have the tegmen tympani, where there is the trigeminal ganglion lying in the Meckel's cave. Laterally on the petrous temporal, on the temporal bone, you have the tegmen tympani, which covers the mastoid air cells, and if in chronic suppurative otitis media, if it ruptures, then there can be a temporal lobe abscess. Coming to the posterior cranial fossa, you have the occiput in front of the foramen magnum, forming the spheno-occipital suture, which fuses at 25 years of age. On the two sides, you have the passage for the inferior petrosal sinus, which is going into the jugular foramen. You have two foramen, which you can see in the foramen magnum area, which is for the hypoglossal nerve. Then you have on the petrous temporal bone, just above the jugular foramen, the internal acoustic meatus. Then you have the internal occipital crest behind the foramen magnum, and the space which is marked by the transverse sinus and the sigmoid sinus going into the jugular foramen. So the jugular foramen, you have the inferior petrosal sinus and the sigmoid sinus forming the internal jugular vein, and it gives passage to the 9th, 10th, and 11th nerve. The internal acoustic meatus gives passage to the 8th nerve and the 7th nerve, and the anti-inferior cerebellar artery and the ductus endolymphaticus. So, this is about the basis cranii interna. In the basis cranii externa, in front you see the alveolar arch and you see the nasal cavity. Then you see the nasopalatine foramen in the front. Then you see the hard palate, the greater palatine foramen, and the palatine ridge. The hard palate, there is a cruciate fissure. The anterior part is formed by the base of the maxilla bone. The posterior part is formed by the horizontal plate of the palatine bone. So there is a greater palatine foramen at that junction. Then you have the pterygoid hamulus of the medial pterygoid plate and the lateral pterygoid plate. Between it you see the posterior nares and the vertical septum of the nose. Then you see the infratemporal fossa, which is formed by the horizontal part of the greater wing of sphenoid. Between the pterygoid plate and the maxilla, you see the pterygomaxillary fissure. Then you see the temporomandibular joint, the fossa for the head of the mandible. Then you see the zygomatic arch. And then you see the styloid process, the mastoid process, the petrous temporal bone housing the carotid canal leading to foramen lacerum, Then you see the base of the occiput, the foramen magnum. On the two sides is the occipital condyle, and you see the two foramen for the 12th nerve. Then you have the external occipital crest leading to external occipital protuberance, the highest nuchal line giving rise to the occipitalis muscle, the superior nuchal line arising from the external occipital protuberance going to the mastoid process would give rise to the trapezius on the medial third and sternocleidomastoid on the outer third, and the highest nuchal line on which you study the suboccipital triangle. So this ultimately completes a quick revision of the skull, the basis craniae interna and externa, once you have really memorized it. Thank you.